Chapter 4 Disorders of Thought and Speech. Disorders of thought include disorders of intelligence, disorders of stream of thought, obsession and compulsions, disorders of the content, disorders of position of thought, and disorders of form of thinking. And disorders of speech include stammering and stuttering, mutism, talking past the point, neologisms, schizophasia, and aphasia. Let's first discuss disorders of thinking. There are three legitimate uses of the word think. These are: the first is undirected fantasy thinking, which in the past has been termed autistic or heuristic thinking. The second is imaginative thinking, which does not go beyond the rational and the possible. And the third is rational or conceptual thinking, which attempts to solve a problem. Disorders of intelligence. The measurement of intelligence is both complex and controversial. For historical reasons, most intelligence tests are designed to give a mean IQ of the population of 100 with a standard deviation of 15. Even if the distribution of scores is not normal, percentiles can be converted into standard units without difficulty, and this is probably the best way of measuring intelligence. Towards the lower end of the range, there is an increase in the incidence of low intelligence that is the result of brain damage caused by inheritance disorders, birth trauma, infection, and so on. There are therefore two groups of subjects with low intelligence, or what is now termed as learning disability or intellectual disability. The first group comprises of individuals whose intelligence is at the lowest end of the normal range and is therefore a quantitative deviation from the normal. And the other group comprises of individuals with specific learning disabilities. Many cases of learning disability are of unknown etiology, and thus, regardless of the cause, they are categorized as borderline, mild, moderate, severe, and profound. Dementia is a loss of intelligence resulting from brain disease characterized by disturbance in multiple cortical functions, including thinking, memory, comprehension, orientation, among others. Individuals with schizophrenia tend to exhibit specific deficits in multiple cognitive domains, and these deficits have in the past been termed schizophrenic dementia. Impairment of working and semantic memory has been linked to the dysfunction of temporal cortex, frontal cortex, and the hippocampus. Coming on to disorders of stream of thought. These can be further divided into disorders of tempo and disorders of continuity. Let's first discuss disorders of thought tempo. These include flight of ideas, inhibition or slowing of thinking, and circumstantiality. In flight of ideas, thoughts follow each other rapidly. There is no general direction of thinking, and the connections between successive thoughts appear to be due to chance factor, which however can usually be understood. The absence of determining tendency to thinking allows the association of the train of thought to be determined by external stimuli, chance relationships, internal superficial associations, and verbal associations of all kinds such as assonance, alliterations, clang associations, proverbs, maxims, and cliches. Flight of ideas are typical of mania. In hypomania, the so-called ordered flight of ideas or prolixity occurs, which is a milder version in which, despite many irrelevances, the patient is able to return to the task in hand. Flight of ideas can occasionally occur in individuals with schiz when they are excited, and in individuals with organic states such as lesions of the hypothalamus. Flight of ideas without pressured speech occurs in some mixed affective states. In inhibition of thinking, the train of thought is slowed down and the number of ideas and mental images that present themselves is decreased. This is experienced by the patient as difficulty in making decisions, lack of concentration, and loss of clarity of thinking. It is seen in both depression and in the rare condition of manic stupor. But in depression, the slowing of thinking is mostly due to anxious preoccupations and increased distractibility due to anxiety. Interestingly, the apparent cognitive deficits may lead to a mistaken diagnosis of dementia. In circumstantiality, the thinking proceeds slowly, with many unnecessary and trivial details, but finally the point is reached. It can occur with learning disability in individuals with obsessional personality traits, schizophrenia, and schizoaffective disorders. But historically, this disorder has been regarded as a feature of the constellation of personality traits associated with epilepsy. Disorders of continuity of thinking. These include perseveration and thought blocking. In perseveration, mental operations persist beyond the point at which they are relevant and thus prevent progress of thinking. It is mainly verbal or ideational. This symptom is related to the severity of the task, so that more difficult the problem, more likely it will occur. This is not a problem of volition, which helps differentiate it from verbal stereotypies, which is a frequent, spontaneous repetition of a word or phrase that is not in any way related to the current situation. Perseveration is common in generalized and local organic disorders of the brain, and when present, provides a strong support for the same. Thought blocking occurs when there is a sudden arrest of the train of thought, leaving a blank, and an entirely new thought may then begin. It differs from the more common experience of suddenly losing one's train of thought, which tends to occur when one is exhausted, distracted, or very anxious. When thought blocking is clearly present, it is highly suggestive of schizophrenia. Obsessions, compulsions, and disorders of the possession of thought. In some psychiatric illnesses, there is a loss of control or sense of possession of thinking, and these include obsessions, compulsions, and thought alienation. Obsessions, also termed ruminations, are thoughts that persist and dominates an individual's thinking despite the individual's awareness that the thought is either entirely without purpose or else has persisted beyond the point of relevance or usefulness. Important features are that their content is often of a nature as to cause the sufferer great anxiety and even guilt and appears against the patient's will. Interestingly, only those mental events can become obsessions that are normally under the control of the patient. Thus, one cannot have obsessional hallucinations or mood. Sometimes, obsessional imagery can be so vivid that they can be mistaken for pseudo-hallucinations. Obsessional fears and phobias consist of groundless fear and must be distinguished from the hysterical and learned phobias. Coming on to compulsions, which are merely obsessional motor acts. They may result from an obsessional impulse that leads directly to the action, or they may be mediated by an obsessional mental image or thought. One common example being when the obsessional fear of contamination leads to compulsive washing. Obsessional impulses may be the impulses to touch, count, rearrange objects, or to commit antisocial acts. Obsessions may occur in obsessional states, depression, schiz, and occasionally in organic states. Compulsive features appear to be particularly common in post-encephalitic Parkinsonism. In certain patients, it may be difficult to distinguish between obsessive-compulsive disorder and psychosis, as up to 14% of patients with OCD may report psychotic phenomena such as delusion and hallucinations or other thought disorders. Coming on to thought alienation. In this, the patient has the experience that their thoughts are under the control of an outside agency or that others are participating in their thinking. Though not diagnostic, this is an important component of the diagnostic criteria for schizophrenia. In pure thought insertion, the patient knows that thoughts are being inserted into their mind and they recognize them as being foreign and coming from without. This symptom, although commonly associated with schiz, is not confirmatory. In thought deprivation, the patient finds that as they are thinking, their thoughts suddenly disappear, withdrawn from their mind by a foreign agency. It has been suggested that this is the subjective experience of thought blocking and omission. Thought broadcasting has been defined in multiple ways. According to Fish, the patient knows that as they are thinking, everyone else is thinking in unison with them. Other definitions are: one's thoughts are quietly escaping from one's mind and that other people might have access to them, or hearing one's thoughts spoken aloud and believing that as a result other people can also hear them. As the individual develops insight into their symptoms, the experience of thought alienation may shift from egosyntonic, that is, the experience is consistent with the goals and needs of the ego, or consistent with the individual's self-image, to ego-dystonic, which means the opposite. Coming on to disorders of content of thinking. Let's discuss primary delusions in detail. Delusion is a false, unshakable belief that is out of keeping with the patient's social and cultural background. These are result of primary delusional experience that cannot be deduced from any other morbid phenomena. On the other hand, delusion-like ideas can be understandably derived from some other morbid psychological phenomena, thus are also described as secondary delusions. Overvalued idea is another important type of false belief and can occur in individuals both with and without mental illness. This is the thought that because of the associated feeling tone takes precedence over all the other ideas permanently or for a long time. These are less fixed than delusions and tend to have some degree of basis in reality. Primary delusions. Primary delusional experiences were once thought to be diagnostic of schizophrenia. Also termed epiphany, in this a new meaning arises in connection with some other psychological event. Schneider divided these into delusional mood and delusional memories, which was again divided into delusional perception and sudden delusional ideas. In delusional mood, the patient has the knowledge that there is something going on around him that concerns him, but he does not know what it is. The meaning of the delusional mood becomes obvious when a sudden delusional idea or a delusional perception occurs. Delusional perception is the attribution of new meaning, usually self-referential, to a normally perceived object or event. This new meaning cannot be understood as arising from patient's affective state or previous attitudes, which helps to distinguish it from delusional misinterpretation. For example, a patient with delusions of persecution hears the stairs creak and knows that this is a detective spying on him. This is not a delusional perception, but a delusional misinterpretation. According to Schneider, delusional perception differs from sudden delusional idea as it has two-memberedness. As the name suggests, two-memberedness has two links. The first link is from the object to the subject's perception of this object, and the second link is the new significance attached to this perception. A patient says that they are of royal descent because they remember that the spoon they used as a child had a crown on it. This is a delusional perception because there is the memory and also the delusional significance forming two-memberedness. In sudden delusional idea, a delusion appears fully formed in the patient's mind. This is also sometimes known as autochthonous delusions. For example, if the patient says that they are of royal descent because when they were taken to a military parade as a child, the king saluted them, then this is a sudden delusional idea because the delusion is contained within the memory and there is no two-memberedness. Primary delusional experiences tend to be reported in acute schizophrenia but are less common in chronic schiz, where they are buried under a mass of secondary delusions. Now these examples have always confused me, as both seem to have two-memberedness, that is, the primary perception and the secondary self-referential inference, which is common in both the examples, that is, the delusion of royal descent. In the first example, the primary perception is of the crowned spoon, and in the second example, it's the salute by the king. I think the second example qualifies even better for two-memberedness, as the salute only happened once. On the other hand, the crowned spoon must have been with the family for a long time, and therefore is less likely to form a singular perception, but rather a continuous memory, and thus can be better understood as a sudden delusional idea. If you have anything to add, please comment. Coming on to secondary delusions and systematization. As previously stated, secondary delusions can be understood as arising from some other morbid experiences. It is now thought that delusions can be secondary to depressive moods, hallucinations, and psychogenic or stress reactions. For example, acute polymorphic psychotic disorders in ICD-10 and brief psychotic disorder with marked stressor in DSM-5. Personality can also play a role in the genesis of delusional states. For example, suspicious personalities can react to difficulties with deepening ideas of persecution, or may slowly develop delusions of marital infidelity or bodily ill health. On the other hand, sensitive personality may be overly sensitive about some real or perceived psychological, social, or physical feeling that the patient felt held them back in some way. Full-blown paranoid psychosis may occur following a stressful event. This disorder, previously known as sensitive Beijing-Schuon, is now classified as delusional disorder in ICD-10. In schiz, the PDEs are commonly integrated into some sort of delusional system. This elaboration of delusions is called delusional work. Some practitioners still divide delusions into systematized and non-systematized. In systematized delusions, there is one basic delusion, and the remainder of the system is built logically around this error. And in non-systematized, the different delusions are not well connected or are not connected at all. Coming on to content of delusions. The delusional content in schiz is dependent to a greater or lesser extent on the social and cultural background of the patient. Some common general themes include persecution, jealousy, love, grandiosity, ill health, guilt, nihilism, and poverty. Delusion of persecution. The word paranoid is commonly used as a substitute for the word persecutory, but the correct meaning is delusional. Paranoia is the Greek for by the side of the mind, and used in the late 19th century to designate functional mental illnesses in which delusions were the most prominent feature. Delusions of persecution may occur in the context of PDEs, auditory hallucinations, bodily hallucinations, or experiences of passivity. It can take many forms. For example, in delusion of reference, the patient knows that people are talking about him, slandering him, or spying on him. And these are not confined to schiz and can occur in other illnesses such as severe depressive illness, the psychotic symptoms, in which the patient believes that they are extremely wicked and therefore justifiably being spied upon, imprisoned for life, or even put to death. These supposed persecutors may be people in the environment, such as members of the family, neighbors, or friends, or even political or religious groups of varying degree of relevance to the patient. Another form of delusion of persecution is the delusion of being poisoned or infected. Patients who are morbidly jealous might believe that their spouse is poisoning them. Often, these are explanatory delusions. In this, the patient feels mentally or physically changed, and the only way in which he can account for this is by assuming that his food is being poisoned. Delusion of reference can also take the form of delusion of influence. These passivity feelings may be explained by the patient as the result of hypnotism, demonic possession, witchcraft, radio waves, atomic rays, or television. Coming on to delusion of infidelity. The commonly used term delusion of jealousy is a misnomer, as patients tend to have morbid jealousy with delusion of infidelity. It is not uncommon in individuals with schiz, affective psychosis, and in a variety of organic brain disorders, but are specially associated with alcohol dependency syndrome. It may develop gradually, and the severity might also fluctuate over time, but during episodes of marked disturbance may progress to violence and even murder. Interestingly, these patients tend not to show any other symptom that would suggest schiz. Delusions of love, also known as the fantasy lover syndrome or erotomania. The patient is convinced that some person is in love with them, although the alleged lover may never have spoken to them. They may pester the victim with unwanted attention, and when the many letters go unanswered, they may claim that their letters are being intercepted. Interestingly, sometimes schiz may begin with delusion of a fantasy lover. Grandiose delusions. There is considerable variety in the extent of grandiosity. Some patients may believe they are God, the head of some country, a famous rock star, and so on, while others are less expansive and believe that they are very skilled sportspersons or great inventors. These delusions may be supported by auditory hallucinations or confabulations. In the past, they were associated with general paralysis of the insane, that is neurosyphilis, but now they are most commonly associated with manic psychosis. Delusions of ill health. In this, the patient may believe that they have a serious disease such as cancer, tuberculosis, AIDS, a brain tumor, or that they are incurably insane, and so on. It is a characteristic feature of depressive illness, but are also seen in other disorders such as schiz. As with other delusions, this may develop on a background of concern and may later progress to overvalued ideas or proper delusions. May even involve the patient's spouse or children. As previously stated, hypochondriacal delusions may develop in schiz as a result of somatic hallucinations or a sense of subjective change, or in personality issues. For example, insecure individuals may develop overvalued ideas of ill health that may later become true delusions. The delusion of ill health may also include delusional preoccupation with facial or bodily appearance. In this, the subject is convinced that one or more of their facial or bodily features are disproportionate or disfigured. These patients are placed under delusional disorder as delusional dysmorphophobia or body dysmorphic disorder. Delusion of guilt. This is mostly seen in depression. In mild cases, the patient may be somewhat self-reproachful or self-critical. But in severe depressive illnesses, the self-reproach may take the form of delusional guilt, and the patient may claim that they are a bad or evil person, have committed an unpardonable sin, or that they will rot in hell. In very serious cases, the delusions may even appear to take a grandiose character, and the patient may assert that they are the evilest person in the world, or that they are the most terrible sinner who ever lived. The delusion of guilt may also give rise to delusional persecution. Nihilistic delusions, also known as delusions of negation, and in this the patient denies the existence of their body, their mind, their loved ones, and even the world around them. Tends to occur in the context of severe agitated depression, schiz, and states of delirium. Sometimes these are associated with delusions of enormity, when the patient believes that they can produce a catastrophe by some minor action. Delusions of poverty. As the name suggests, in this the patient is convinced that they are impoverished and believe that destitution is facing them and their families. It is typical of depression, but appears to have become steadily less common over the past decades. The reality of delusions. In acute phases or during exacerbation, individuals with delusions may act on their delusional beliefs. For example, hypochondriacal delusions may lead to suicide, or if they involve the patient's family, homicide. Depressed patients with severe delusion of guilt may try to give themselves up to the police. Interestingly, when the delusional illnesses become chronic, there is a discrepancy between the delusions and the patient's behavior. For example, patients who believe they are being poisoned may be happy to eat hospital food. The pathology underlying delusions. Attempts to explain delusions focus on developing models of the cognitive underpinnings of delusional beliefs and using novel neuroimaging techniques to identify brain areas or processes involved in developing and maintaining delusions. Contribution to the cognitive perspective were made by the following. Huck and colleagues showed that individuals with delusions tend to make guesses based on less evidence than individuals with psychiatric illnesses who do not have delusions. Garrity and colleagues found that individuals with delusions tend to change their minds more rapidly than individuals without delusions. Bentall devised a useful heuristic model of the perceptual and cognitive processes that help with the development and maintenance of delusions. Gilleen and David provided a valuable review of the cognitive neuropsychiatry of delusions, focusing on reasoning biases, attentional and attributional biases, and the relevance of emotion and the theory of mind. And Petrolini showed delusions may involve both executive and emotional dysfunctions. The neuroimaging perspective suggested associations between types of delusions and different aspects of brain structure, such as abnormalities of cingulate gyrus activation and persecutory delusions, and entorhinal cortex pathology and positive symptoms such as delusions. Coming on to disorders of form of thinking. The term formal thought disorder is a synonym for the disorders of conceptual or abstract thinking that are most commonly seen in schiz and organic brain disorders. Bleuler regarded schizophrenia as a disorder of associations between thoughts, characterized by the processes of condensation, displacement, and misuse of symbols. In condensation, two ideas with something in common are blended into one false concept. In displacement, one idea is used for an associated idea. And misuse of symbols involve using the concrete aspects of the symbol instead of the symbolic meaning, also known as concrete thinking. Cameron used the terms asynthesis, metonyms, and over-inclusion. Asynthesis is the lack of adequate connections between successive thoughts. Metonyms is the use of imprecise expressions instead of more exact ones. And over-inclusion is the inability to narrow down the operations of thinking and bring into action the organized attitudes and specific responses relevant to the task at hand. Goldstein also described loss of abstract attitude, which leads to concrete style of thinking, despite the fact that the patient has not lost their vocabulary, unlike the patients with organic brain disorders. Schneider identified 5 features of FTDs. In derailment, the thought slides onto a subsidiary thought. In substitution, a major thought is substituted by a subsidiary one. Omission is a senseless deletion of a thought or part of it. In fusion, heterogeneous elements of thought are interwoven with each other. Drivelling is the disordered intermixing of constituent parts of one complex thought. He suggested there were 3 features of healthy thinking: constancy, organization, and continuity. Constancy is the characteristic of a completed thought that does not change in content unless and until it is superseded by another consciously driven thought. Organization states that the contents of the thought are related to each other but are separated in an organized way. And in continuity, there is a sense of continuum, so that even the most heterogeneous subsidiary thoughts, sudden ideas, or observations are arranged in a proper order. There are 3 corresponding varieties of objective thought disorders. The first one is transitory thinking. It is characterized by derailments, substitutions, and omissions. Omission can be distinguished from desultory thinking because in desultoriness, the continuity is loosened, but in omission, the intention itself is interrupted and there is a gap. And the grammatical and syntactical structures are both disturbed. The second is drivelling thinking. In this, the patient has an outline of a complicated thought with all its necessary particulars but loses organization so that all the constituent parts get muddled together. Third is desultory thinking. In this, the speech is grammatically correct but sudden ideas force their way in from time to time. Each one of these ideas is a simple thought that, if used at the right time, would be quite appropriate. A study identified 3-factor model as the best with the following dimensions: disorganization, poverty, and verbosity. It also found that around 20% of patients display verbosity, around 21% have clinically significant FTD, around 24% had impoverished speech, and around 41% showed evidence of disorganized speech. The neurobiological underpinnings of FTDs remain unclear, but there is evidence of genetic influence, synaptic rarification in the glutamate system of the superior and middle lateral temporal cortices, diminished cortical volume of the left superior temporal gyrus, reversed hemispheric activation during speech production, and somatic network dysfunction. Coming on to speech disorders. Disorders of speech are seen in a broad range of psychiatric and neurological disorders. They include stammering and stuttering, mutism, talking past the point, neologisms, schizophasia, and aphasia. Stammering and stuttering. In stammering, the normal flow of speech is interrupted by pauses or by repetition of fragments of the words. Grimacing and tick-like movements of the body are often associated with stammer. Usually begins at the age of 4 years and is more common in boys than in girls. Often it improves with time and may only become noticeable when the person is anxious. Sometimes it persists into adult life when it may be a significant social disability. Occasionally it occurs during severe adolescent crisis or at the onset of acute schiz. Mutism. In this, there is complete loss of speech and may occur in children with a range of emotional or psychiatric disorders. Elective mutism may occur in children who refuse to speak to certain people. In adults, it can be seen in hysteria, but hysterical mutism is relatively rare. Severe depression with psychomotor retardation may be associated with mutism, but then more often there is poverty of speech. Mutism is almost always present in catatonic stupor, and finally mutism can also be seen in organic brain disorders, such as in akinetic mutism, which is associated with lesions of the upper midbrain or posterior diencephalon. Talking past the point or Overvalued. In this, the content of the patient's replies to the question shows that they understand what has been asked, but have responded by talking about an associated topic. For example, if asked what is the color of grass, the patient may reply white. It may occur in hysterical pseudodementia, which is now classified as dissociative or conversion disorder, Ganser syndrome, acute schiz, especially hebephrenic, and among adolescents, also known as pseudodementia, and in catatonic states. Neologisms. These are new words that are constructed by the patient, or ordinary words that are used in a new way. Some patients use a stock word instead of the correct one. For example, a patient may use the word car and call an airplane an air car or a boat a sea car. Others may be the result of FTD. In fusion, words are fused together in the same way as concepts are blended. And in derailment, a patient used the word relativity instead of the word relationship. or can be a result of patient's attempt to make up a technical term for a private experience that cannot be expressed in ordinary words. This can be called a technical neologism. In some cases, hallucinatory voices may play a part in the formation of neologisms, as the voices might use the word which leads the patient to use them as well. Neologisms are usually seen in schiz, in which the patient may produce a completely new word, its derivation may or may not be understood, may be a distortion of another word, or it may be a word that has been incorrectly constructed. In motor aphasia, these are actually paraphasias, which might resemble neologisms. In catatonic patients, neologisms may be a part of mannerisms or stereotypies. Malapropisms are consciously misused words, may be mistaken for neologisms in some individuals, but are themselves of no particular known psychiatric importance. Speech confusions and schizophasia. Schizophasia is generally regarded as a form of thought disorder, therefore it is also known as speech confusion or word salad. Schizophasia has a superficial resemblance to aphasia, where the disorder of speech is much greater than the deficit in intelligence. Some patients produce speech that is profoundly confused, but are able to carry out responsible work that do not involve the use of words. Aphasia. These are tend to be classified into three groups: receptive, intermediate, and expressive. There are three types of receptive aphasias. The first is pure word deafness. These patients hear words but cannot understand them. This is generally attributed to a lesion in the dominant temporal lobe. The second one is agnostic alexia. These patients can see but cannot read words. This is generally attributed to lesions in the left visual cortex and in corpus callosum. The third one is visual asymbolia or cortical visual aphasia. In this, there is disorganization of visual word schemas so that the words cannot be recognized and the motor word schemas cannot be activated. Generally attributed to lesions involving angular and supramarginal gyri. Is often associated with other neurological disorders such as acalculia, spatial disorientation, visual agnosia, nominal aphasia, and right homonymous hemianopia. These patients are able to understand spoken words but have difficulty to read and write spontaneously, but can copy writing to some extent. Agnosias are related to receptive aphasias. In these disorders, the patients experience sensation in a given modality but they cannot recognize objects. For example, in visual agnosia, the patient can see but cannot recognize what they see, but can recognize the object if they feel them. These patients can neither describe nor use the object, so that there is both aphasia and apraxia. Coming on to intermediate aphasias. As the name suggests, both the receptive as well as the expressive aspects of the speech may be affected. Has two main types. The first one is nominal or amnesic aphasia. In this, the patient cannot name objects, although they have plenty of words at their disposal. They find it difficult to carry out verbal and written commands. They can copy written material but cannot write spontaneously. May be seen in diffuse brain damage or focal lesions involving temporoparietal region. The second one is central or conduction or syntactical aphasia. In this, the patient experiences substantial disturbance in language, speech is faulty in grammar and syntax, and there is paraphasia. May result from a number of different lesions. Finally, coming on to expressive aphasias. The main type is cortical motor aphasia, also known as Broca's verbal or expressive aphasia. In this, the patient has difficulty putting their thoughts into words. And in severe cases, the speech may be restricted to expletives and a few words, and in some cases may only use one paraphasic word. These verbal stereotypies are produced with different intonations to produce different meaning. One example might be "I am Groot" from the Guardians of the Galaxy movies. But the patient under stress might say some words. The patient realizes that they are making mistakes and tries to correct them. The omission of articles and short words give rise to a telegram style of speech. The expressive quality of speech is disordered so that the intonation and stress are unusual and speech sounds stilted and odd. Serial responses are often not affected so that the patient may be able to count, recite the alphabets, and give the days of the week. The last one is pure word-dumbness. These patients are unable to speak spontaneously, to repeat words, and to read aloud. But they can write spontaneously, copy, and write to dictation. This disorder probably results from a lesion beneath the region of the insula.